All right, everyone, we are going to get started right now, and I would like to introduce our speaker for this evening, Dr. James Wysock, who is a urologic oncologist here at Perlmutter Cancer Center, and he's going to talk to us tonight about prostate cancer from diagnosis to treatment. Let's welcome Dr. Wysock.
All right, thank you everyone. Good evening, late afternoon. Just want to give a talk today on some of the aspects about prostate cancer from beginning of the diagnosis to some things that we do here at NYU in terms of treatment. And I think we'll try to cover a broad range of topics, and at the end we can discuss some questions if you have any. Let's go ahead and begin. So what I'd like to start with is a little review of what exactly the prostate is, what is its anatomy, what's around the prostate, the surrounding structures and other anatomical considerations of where the prostate is play a very important role in how prostate management is decided, because there are many impacts on surrounding organs, and a lot of these arise from exactly where the prostate is located. So this is an MRI image here on this right side of the screen, which I think is, I'm going to go through a series of these because I think they very nicely illustrate some of the very important considerations when we're talking about the prostate. So what is the prostate? It's a sexual accessory organ. Okay, many men don't even realize what the prostate does. The prostate produces semen. That's its purpose, is to make fluid to help transport sperm for fertility purposes, for reproduction. What else does it do? Well, it can grow as we age. It's hormonally sensitive, and as we age, we continue to make testosterone, and it continues to respond to that testosterone, and it grows, and that can lead to urinary obstruction. It is a pelvic organ, and so this image on the right is showing you a picture of the pelvis from a side view. So we're looking from one hip across the body to the other hip. And so on the left portion of this screen is the abdominal wall, or the lower abdominal wall, and on the right portion of the screen, this is the tailbone, if you will. Okay, there's some intestines here, and I've highlighted a few of the important anatomical structures and their relationships. This is the urinary bladder just behind the pubic bone. The urine passes through what's called the prostatic urethra, which goes through the prostate, which I've highlighted in this greenish color, and then out through the urethra, the bulbar and pendulous urethra, which this is the base of the penis. This is very important. These structures are all intimately associated with one another. They're right next to one another. Here's the rectum just behind the prostate. So you can see in the pelvis, it's really crowded real estate. There's a lot of activity in a very small area. This is very important when we talk about prostate treatment and management. This is another picture of the prostate. This is what we call a transverse or an axial view. So this is a picture of the prostate with a man lying on his back. We're looking from the feet towards the head. And so it's if you can imagine, if you were lying down, a slice through your pelvis. On the anterior surface, this is sort of where the pubic bone would be. Here's the rectum on the back side. And this illustrates very nicely. If I do a digital rectal exam and put my finger in the rectum, you can see it's right up against the prostate there. That's how you feel the prostate. But important to note, I'm only feeling that half of the prostate with an examination. It's an important consideration when we talk about examining the prostate. It's limited in that it can only feel this part of the prostate. Now, the prostate's also very closely involved in sexual function. I mentioned already that it makes semen, but there's a very important other component that the prostate itself doesn't do, but is right next to the prostate, and that's called the neurovascular bundles. And I've highlighted them on the MRI here in green. They are on the back side of the prostate. We call it the posterolateral aspect of the gland. Just on the back side of the prostate, there's these two areas that are full of blood vessels and nerves that run behind the prostate to the base of the penis, and these are responsible for erections.
What are they called again?
Neurovascular bundles. Also important, and I've highlighted it in red here, is what we call the dorsal vascular complex, or the dorsal venous complex. And this is a series of blood vessels on the top part of the prostate that essentially run directly to and from the penis. Erections are a vascular event. the penis fills with blood, it becomes firm, and then when the vascular tone decreases, the blood leaves. And so this is why this is very important, because those blood vessels and those nerves are all around the prostate. In fact, they envelop the prostate. So anything we do to the prostate could affect this aspect of physiology. What's another component of sexual function? Well, how do you get semen out of the body? Semen goes from the prostate and into the urethra through what we call the ejaculation process. And there are, at the base of the prostate, now this is a coronal picture of the prostate. What I mean by that is this is a picture on the MRI with a man standing up. So you're looking at the pelvis as if you were looking at someone standing up. So in this picture, this is the urinary bladder. This structure, which I've tried to outline in blue, are called the seminal vesicles. These are two organs that are attached to the prostate at the very base of the gland where semen is stored. Remember, the prostate produces the semen and it gets stored in the seminal vesicles. Those combine with the vas deferens. You've all heard of a vasectomy. A vasectomy means the tube that comes from the testicle to the prostate where the sperm go, and they join up with the seminal vesicles in what's called the ejaculatory duct. This is how you get ejaculate. Ejaculate is the semen plus the sperm. So the vas deferens connect to where the semen comes into the prostate, and all of that is combining in the prostate. So again, the prostate is intimately involved in all of these functions. Erections because of the neighboring neurovascular bundles, but all of the sexual and ejaculatory functions come from the prostate. It's very important to be knowledgeable about what these anatomical considerations are, because when we talk about diagnosing and treating prostate cancer, all of this is at play. All of our treatments could affect these functions. And this doesn't even mention the fact that the urine passes through the prostate. And I should, in the future, add a slide showing some of those critical structures. Now, prostate cancer is still the number one most common solid malignancy in men in the United States. It is the most common solid malignancy in men worldwide, with over 1.2 million cases being diagnosed in 2018 and over 300,000 deaths in the world. In the United States, currently, the lifetime risk of being diagnosed with prostate cancer is about 1 in 6, 17% lifetime risk. Okay. Now, the incidence of prostate cancer diagnosis in the United States for many years actually was pretty flat, but then in the late 80s, early 90s, we saw a big spike, and that was related to the introduction of PSA screening, and I'm going to go through that. And during that period, because of the use of PSA screening, we also started to detect the disease at a much younger age. And so in 1985, the median age that we diagnosed men with prostate cancer was in their 70s, and by 2012 it had dropped about 5 years to 67. So we started to detect the disease much younger, much earlier. So are there signs and symptoms of prostate cancer? How do you know you might be at risk other than just having a prostate? Well, prostate symptoms are common. Prostate symptoms are common. But prostate cancer in its own right, those symptoms are not specific for the cancer. So urinary slowness, meaning the stream isn't as strong as it used to be, difficulty emptying your bladder, waking up at night to urinate more than once, those are symptoms of prostate growth. They are not specific for prostate cancer, but they could be a sign or a symptom that something's going on with your prostate, but in no way are they specific for cancer. Blood in the urine is something that you may hear about, or blood in semen or ejaculate, or the lack of ejaculate or loss of ejaculate. These could be signs and symptoms of prostate cancer. And inability to urinate. This could be a sign of prostate cancer. However, none of these, like I said, and I need to stress, are absolutely signs of prostate cancer. They could just be prostate growth signs, symptoms. In fact, they are all much more likely to be due to benign growth of the prostate. We call that benign prostatic hyperplasia. So what are the risk factors? The known risk factors. I often get asked by men, what can we do to prevent this? What are the known risk factors for prostate cancer? The number one, absolute most important, is age. And There's nothing I can do to prevent that. Ethnicity, genetic factors, and there are some possible dietary factors. And I'll go through some of this in a little bit of detail. But age is the strongest. Prostate cancer has one of the strongest relationships with age. We find more of it in older men, period. You know, it's just a phenomenon. And you can see on the graph here on the right, the incidence of prostate cancer diagnosis rises every decade. Now, it levels off here on this study in the 70s and 80s, and it's very rare before age 40. But anywhere from 50 onward, the incidence is increasing, and the peak incidence is probably in the mid-60s to mid-70s. I don't know why. No one really knows why, but that is the most important risk factor, okay? Ethnicity, there is some data to say that there are ethnic risk factors associated with prostate cancer. So the annualized incidence rate for men in their early 70s per 100,000 men would be highest rate of prostate cancer diagnosis in African American men, followed by Caucasians, and the least would be identified in Asian Americans. Now, this is a multifactorial question. Does ethnicity really influence it? There are many factors that go into this, but these are observational data that suggest that the rate and the incidence of prostate cancer in these ethnic groups fall in these lines. We don't exactly know why. There are many, many factors that go into this. But there are multiple studies in the United States showing that African American men do have a higher likelihood of being diagnosed with prostate cancer and a higher rate of aggressive disease at the time of diagnosis. So it is something as a physician I always keep in mind when counseling men of African American heritage in terms of their screening and in terms of what their treatment options might entail, especially when we're talking about active surveillance versus active treatment, because it is important to keep that in mind. Dietary factors. I'm going to go through some of these because this is important. I get asked about this a lot. What can I do or eat to help my prostate be free of cancer? And the bottom line here is there's not a lot of great data here. Okay? This is not hard science, and you will be, and I must stress that you have to be careful in interpreting what is out there on the internet or what people might say, because a lot of this comes from what we call observational data. It is not cause and effect data. It is not a study where we gave someone, a particular food, randomized it to somebody who didn't get that food, and we know that there's an absolute cause and effect. These come from population-based data sets where we can see a relationship. One of the risk factors that looks like it could be related to not just prostate cancer, but many cancers, are animal fats. Alpha-linoleic acid, it's present in red meat and dairy products that appears to increase the risk of prostate cancer. Okay? Vegetables, conflicting data, but it looks like vegetables like cauliflower, broccoli, possibly lower the risk. Interestingly, what does that sound like? That sounds like a heart-healthy diet, right? That sounds like the same dietary advice that we do have good evidence on for vascular health. Interesting how that falls out in the same way. But I would stress these are observational data points for prostate cancer. So I'm not endorsing you don't eat meat to prevent prostate cancer because I don't know if that will happen. But there is some suggestion that there is a higher risk with heavy meat diets. But that actually has been shown for many cancers, not just prostate cancer. Cause and effect unclear. Tomatoes. Tomatoes contain a component called lycopene. This has been studied. The data is not clear. However, it does look like tomatoes may help lower risk. Now, if I told you that something may help lower the risk, go ahead and do it. You have to balance benefit versus risk. There might be a benefit. What's the risk of eating too many tomatoes? Well, there's not much risk to that. So I feel comfortable telling men, eat as much lycopene as you'd like. If you're having tomatoes, it's fine, right? I don't see a lot of downside to eating tomatoes. And that goes similarly with soy, for example. So soy is a phytoestrogen. And this is hypothesized to play a role in why there is a lower rate of prostate cancer in Asia. There's a heavy use of soy in the diet in Asia, and there is an anti-testosterone component to soy. The phytoestrogens behave a little bit like estrogen. They may actually block some of the activity of testosterone at the level of the prostate, and this may suppress prostate cancer inducing effects that testosterone would cause. Subsequently, soy may be beneficial. It may lower your risk of prostate cancer. I don't know. It's not a cause and effect study. But again, what's the downside to having more soy sauce or soy-based products, tofu, etc.? I think it's pretty low, so go ahead and eat it. I would endorse that, So I don't see a problem with it, but I can't say for certain how effective it would be. Alcohol, mixed results. Some studies say red wine is helpful. Some studies say no effect, okay? So I can't really say much on that. Coffee appears to be related to a decreased risk of lethal prostate cancer. Again, not a cause and effect, but coffee didn't show the opposite, and I don't think there's a lot of downside to having coffee, okay? Now, one thing that does come up is an important finding that came out of some data on multivitamins, and specifically vitamin E. Vitamin E may have a possible risk of increasing prostate cancer. So if you have a high level of vitamin E supplementation that you're taking, that doesn't look to be something that I would endorse. Selenium was also studied in this. There was some hypothesis that that might help, but again, the selenium was looked at as potentially preventing prostate cancer. Did not look like that actually works, but vitamin E may actually be harmful. Okay, zinc, possible increased risk there as well. Again, very weak data. Calcium and vitamin D, you'll hear things about that. Conflicting data. Fish oil, omega-3 fatty acids. A couple studies say maybe that actually increases risks. Again, 5 years ago they would say that's protective. 5 years later, a study comes out and says it's not. All of this is very important to keep in mind when you hear these things. And the reason I put this up there is you will hear that these are dietary factors that are associated with these type of cancers, etc. Be very careful in how you interpret them because they are not necessarily cause and effect studies. Observational data. But keep in mind also, what's the risk benefit? Most of these are talking about eating heart healthy diets or vascular protective diets, and I think there is a lot of benefit to that. Solid tumor, prostate cancer may be the number one solid tumor diagnosis of men in the United States, but what's the number one killer in the United States? Vascular disease, cardiovascular disease. So eating for your prostate versus your cardiovascular system, I don't endorse it. Do what we know has very strong evidence base in terms of your cardiovascular health. Those diets are important. This is kind of controversial, but I'm going to mention it because this has come up in a few studies. This is a population-based study that was reported a few years ago on 2 million Danish men who had vasectomy. They had a 15% higher rate of prostate cancer in the men who had a vasectomy versus the men who did not. There's a few other population-based studies that suggest a potential role for this as well, and there are also studies that say the opposite. Very controversial, but as a urologist, if I'm going to perform a vasectomy on a man, I would then let them know there is data out there that suggests the vasectomy may be related to a prostate cancer risk. Cause and effects are unknown, but it is something to keep in mind. The American Urologic Association would tell you there is no increased risk at this point. But in full disclosure, there are some data points out there, and that's the way the AUA approaches this. But we do not have any evidence that is conclusive. Okay, so again, a lot of this, what are the causes of prostate cancer, is hard to pin down. Family history is very important. Okay, if you have an immediate male relative who had prostate cancer, your risk of having prostate cancer increases nearly twofold. If you have 2 or more immediate relatives that have prostate cancer, that can go up to as high as 4 times the general population risk. Approximately 10% of all prostate cancer diagnoses are hereditary. So this is not the majority of the prostate cancer that we're detecting, at least from what we understand right now about the genetics of prostate cancer. Okay, but it is Almost the majority is 40% of the prostate cancers that we're detecting when it's a very early age of onset. And I'm talking the men who are diagnosed in their 40s, etc. This is the more common time that you would suspect a genetic version or an inherited prostate cancer. So most prostate cancer are spontaneous mutation that occurs in the prostate cells, and this is a way that many of cancers are developed. Now, what are some of those genetic risk factors in prostate cancer? Well, there's the BRCA mutation, BRCA, which you've probably heard of. Those mutations are 1 and 2. If there's a family history for that, you might want to get tested. If you have a female relative with ovarian or breast cancer, was tested and found to have a BRCA mutation. As a male relative, it's a good idea to get tested, because your risk of prostate cancer, if you have a BRCA1/2 mutation, appears to be higher. It appears to be earlier onset, and it appears to be more aggressive. Okay, anywhere from 4.5 times the normal rate for BRCA1s, and it can be as high as 8 times the normal rate for BRCA2. BRCA2 is specifically associated with a younger age of diagnosis and higher risk of disease, higher rates of metastatic disease, meaning leaving the prostate gland, and actually higher rates of mortality from prostate cancer in these BRCA2 mutations. Very important to keep that in mind. Now, this is an emerging area, an emerging field, the genetics of these prostate cancers. I don't know what to do necessarily with young men in their 20s and 30s who were referred to me because their sister or their mother were diagnosed with a BRCA2 mutation. They got tested and they have it. I mean, they're at risk, but we don't have good screening guidelines for these situations. But this is an emerging area. There are studies ongoing using some of the tools that I'll talk about later on to try to help screen these men differently, because we would want to catch these cancers sooner because they are more aggressive. Now, if you probably have read or heard about, in the population of women who have BRCA1 and 2 mutations, oftentimes they do prophylactic mastectomies, prophylactic ovary removal, and some of these type of surgeries. We've not endorsed removing the prostate just because you have a BRCA1 or 2 mutation, but that paradigm exists for the mutation in other organs, and so it is something to keep an eye on. There will be work into this as we learn more about these genetics. So, how do we screen for prostate cancer? And this gets at the real crux of what we'll be talking about today. Prostate cancer screening. How do we know if you have prostate cancer? When it's caught early and treated earlier, just like any cancer, that's a better outcome than waiting for it to become symptomatic. This holds true for almost any cancer. If you can catch it when it's not causing symptoms and it's caught early based on a screening method and treat it in that way, it improves outcomes. Colon cancer is a very good model for that. We all have a very easy to obtain test called colonoscopy, which you can do. And if you catch a polyp in the colon before it becomes a large tumor in the colon and treat it in that way, it is proven to decrease the rates of colon cancer deaths. This is a very important concept that the screening for prostate cancer would try to mimic. So how do we do that for prostate cancer? Well, like I mentioned earlier, we have the tool called digital rectal exam. You can go see your urologist or your primary care physician, and they can do a digital rectal exam. And so this is an image of what exactly is going on in the rectum if I put my fingers through the anus and into the rectum and try to feel the prostate. And like I showed you with that MRI image earlier, you're only feeling 1/2 of the prostate gland. Now, importantly, this is typically where prostate cancer would develop, but 20% of the time it could be over here. So you're missing 1 out of 5 potential cancers just based on location alone if you only rely on the digital rectal exam. This was all we had for many years until the late 80s, and prostate-specific antigen, or PSA, became a test that we had available to us to check the blood for risk of prostate cancer. So what is PSA? Prostate-specific antigen. It's an enzyme that can be measured in the blood that's made by the prostate cells. Again, an important distinction here is it is not made by prostate cancer cells specifically, it's made by prostate cells. Prostate benign cells and prostate malignant cells both make the PSA. So the normal biology of a completely healthy, cancer-free prostate will cause PSA to be measurable. So how do we use this to measure prostate cancer? Well, that's a challenge, and I'm going to get into that. But that is part of why the PSA screening is tricky. And you have to do it with a very thoughtful approach. And I'll go through some of those reasons. But PSA is essentially a protease. What I mean by that is it's an enzyme that breaks down other enzymes. It's part of the semen. It liquefies the semen. That's its role. This came to light as a measure for prostate because it was utilized in forensic studies initially. If you had a sexual assault, there was an investigation, and there was some body fluid there. This was specific for semen, and so forensic scientists used this to identify semen and say, hey, yes, there was a sexual assault, this was semen, and then that got translated ultimately into a biomarker for prostate, because only the prostate makes the PSA. Now, what can cause it to go up? You have a healthy prostate, you would make a baseline level of PSA, but if your prostate becomes inflamed from infection, prostatitis, or obstruction, PSA will go up. If your prostate enlarges and you have more prostate cells, your PSA will go up. If I put my finger on your prostate at a digital rectal exam and measure your blood right away, your PSA will go up. If you have a hard bowel movement, there's some hypotheses that that could press up against the prostate. You measure your PSA right off there, it'll go up. Just because the compression on the gland will squeeze some of it out of the enzymes and into the bloodstream, out of the glands. If I do a cystoscopy where I put a camera in the bladder, that could cause it to go up. So there are many things that can actually cause the PSA to go up that are not related to cancer. Very important. Sexual activity can cause the PSA to go up. So if you have sex within 72 hours of your PSA test and it comes back elevated, it could be just related to having sexual activity. Bike riding possibly can create some congestion in the pelvis, the vascular congestion, and may cause it to rise. But this tool is an advance over that digital rectal exam that was all we had. So if you had no symptoms and you had a digital rectal exam and that was all you had to say, okay, I'm cancer-free, come back in a year and I'll check your prostate again, versus having a blood test, which may actually help you find something sooner than the digital rectal exam, or help you find the prostate cancers that you can't feel, that may be beneficial. And so we started using this in the late 80s, early 90s. And what did rolling out PSA screening do? Well, it improved our detection of prostate cancer that was just in the prostate. It did work. We found more prostate cancer early. Okay, the 5 and 10 year prostate-specific survivals improved. Right now, they're in the 100, or not 100, they're in the 90% range because we catch it early and we could treat it. That looks like a success. The rates of biochemical-free survival, meaning if you treat the prostate cancer, does your PSA stay low? That improved. Prostate-specific mortality or death from prostate cancer went down. So everything looked great. We were very happy with the PSA test as a way to improve our detection of prostate cancer and improve mortality from prostate cancer until about 2011. And in 2011, there were 2 studies that were reported upon that were designed to really prove that PSA screening is going to lower prostate cancer mortality. And I'll just go through these in a little bit of detail because I think they're very important because they set off a chain reaction that we're still dealing with today. The first one is called the Prostate, Lung, Colorectal, and Ovarian Screening, or the PLCO screening trial. This is an American study. What they did is they tried to compare rates of prostate cancer mortality between men that had prostate cancer screening with PSA versus none. You were supposed to be randomized. And then you were supposed to, over 11 years, look at the mortality benefit of having that PSA screening. What did they find? Well, they came out and all of their analysis showed PSA screening did not improve mortality with adding the PSA into that DRE. On further analysis, this study is highly flawed. Most of the men in the non-screening arm had PSA screening. So So if they had elevated PSA, they ended up getting investigated for prostate cancer. So it was a highly popular, there was a lot of what we call contamination in the two arms. It was not well performed. But this study got published. It got a lot of headlines. It looked like PSA screening didn't really help. At the same time, in Europe, they ran a trial called the European Randomized Study of Screening for Prostate Cancer. This is on a number of centers throughout Europe, and they showed PSA screening did create a reduction in prostate cancer deaths over a 9-year period, but it looked like you needed to screen 50 men to save one man, and that's what we call the number needed to treat, which means all the burden of the screening and the biopsies, etc., wasn't outweighing the benefit that we were seeing on a population level. So there was some skepticism there. Now, they did see that it improved the prostate cancer mortality, but they weren't overwhelmed by it. They didn't find that it was that strong. Caveats, though, is that that was very early analysis. And when these two studies came out in about 2011, it set off some alarms. And one of the alarm bells was that many of the men that were being identified as having prostate cancer by PSA levels had low-grade disease. We call that Gleason 6 cancer. We call that Gleason grade group 1. And that was a very large component of what the PSA screening was allowing us to identify. So you'd get a PSA test, it was elevated, you'd have a prostate biopsy, and the vast majority of these men would have some low-grade Gleason 6 prostate cancer. You need to get treated. Turns out that small volume, low grade prostate cancer does not often, if ever, cause mortality. And there are two studies that really look at that. This is a study of 14,000 men who had Gleason 6, and there were only 22 men in 14,000 that ever showed metastases from Gleason 6 prostate cancer. And then on retrospective review of those 22 cases, those cases were actually misdiagnosed and had Gleason 7 or higher disease. So they concluded from that study, none of the Gleason 6 disease led to metastatic cancer. And in Memorial, they looked at a cohort of 12,000 men with Gleason 6 disease after their prostate had been removed, and they only had a 0.2% mortality at 20 years. So it looks like if you truly have Gleason 6 disease in a small volume, it's most likely not a malignant cancer. And like I said, the vast majority of the cancers that we're detecting with this PSA screening were falling into this category of small volume, low-grade disease, and men were undergoing treatment for it. And treatment, like I mentioned very early on, because of where the prostate's located, there are some impacts from that treatment. Sexual function, urinary function. So you're starting to see treatment for a disease that may not be that aggressive, with some significant impact on quality of life issues long term. So people start to put together the sum of this data and say, hey, is this PSA screening really helping? And then this came out. I remember I was a fellow when this came out. The United States Preventative Service Task Force is a governmental body that is tasked with telling the senators, the CMS, and Medicare, should you pay for these tests? Well, they came out and said the PSA blood test gets a grade D based on those studies I just mentioned, which means if they send that forward to the government, Medicare is going to say, well, guess what? We're not going to pay for PSA screening because it doesn't do any good. And that means if you go to the doctor's not going to order the PSA for you because they're not going to get reimbursement for it. And no one's going to get PSA screening. So where are we going to go back to? We're going to go back to that picture I showed you earlier on. That's all we'll have. That was last time we relied on that was the mid-'80s. So this was a big deal. This sets off a chain reaction. Now it's important to know that the United States Preventative Service Task Force, who makes this decision, doesn't have any urologists, doesn't have any prostate cancer physicians on their board. It's an interesting dynamic, but it's very controversial how they make decisions based on these studies when they don't have experts within the fields of the area being discussed. Now, this, I won't get into it, but one of the reasons why they made that decision wasn't just the PSA, the PLCO and the RSPC data. It was also because of the overtreatment of the low-risk disease, right? So that was part of their consideration. Now in 2017, they issued an updated guideline and they put PSA back to the grade C. So it is now, it's not great, it's still a grade C, but they didn't get D as a real bad score. I mean, D, when we have a D score, they're not going to cover it. The C still gets coverage, it still can be utilized. And they basically said that the reason why they moved it back to a C is as a community of physicians who take care of prostate cancer, we've really tried to embrace what I call active surveillance, or what we call active surveillance, for men who are diagnosed with low volume grade 6 or low volume small or low grade prostate cancer. Watch it rather than go to full treatment. And that has been endorsed and embraced by the community of urologists, radiation oncologists, medical oncologists, and by endorsing that and not treating those men and not subjecting them to the harms of overtreatment, we've really embraced a different model. They say, okay, yes, so PSA screening can be done better if you think about it better and you don't just knee-jerk treat everyone. And so there are some other caveats in there, and so you have to also use age as a important factor. So for men from 55 to 70, essentially, yes, screening in that point, you have to discuss what the potential harms could be of doing the screening and the risks and benefits. And if you're over 70, they said they will give you a D score for that. And the American Urologic Association came out with some guidelines on this and said basically it's a shared decision making, which just essentially says you just don't go into the office and then somebody draws your PSA and then the next week you get a phone call, hey, it's elevated, come on in for a prostate biopsy. No, you have to say, look, let's talk about your PSA. Let's see if you want to evaluate it. These are some of the pitfalls with the test, and this is what it might mean if it comes back elevated. And this concept really tried to bring it to the forefront that we have to be smarter about how we interpret it and use it. And that is what we do now. We'd always been doing it, but I think this helped reinforce that this is how it should be applied. And so it is not a grade D right now. A lot of that controversy we've gone through, it is a grade C, but it didn't go away. So PSA, we're not back to just that digital rectal exam. This is an AUA's sort of flow chart for should you be screened for prostate cancer. And I'll just take you all through this because I think it's very important. Are you having symptoms is the first box. That's where you'd start, right? So are you having any urinary symptoms, difficulty urinating? If you say yes, well, look, that can be caused by a number of things, but prostate cancer is on that list. You need to talk about your symptoms. Could be a urinary tract infection, could be benign prostate hyperplasia, etc. There's all sorts of things. So then that needs an evaluation of its own right. But if you have no symptoms, are you African American? Remember what I said, that is a potential risk factor for higher grade disease and from everything we can tell. Or do you have a family history, father, grandfather, uncle, brother, or son who had prostate cancer? Yes, talk about PSA screening, okay? If you're 55 to 69, yes, talk about PSA screening. Are you under 40? Probably don't do it. If you're between 40 and 54, you have to be very careful how you interpret it, but in general, you probably don't need it. If you're over 70, here's the question. That's the critical question here. If you're over 70, how healthy are you? Have you had triple bypass surgery? You have diabetes, had a stroke? These sort of things. Or are you out running marathons? These sort of things start to play into whether you need to do aggressive prostate cancer screening in that age range. And so it loops you back to talk to your healthcare provider about whether you should do it. And so this is how shared decision making is supposed to work. So PSA screening, now we're trying to be more judicious in how we apply it and also how we interpret it. So really at the crux of all of this is that low-grade, low-volume disease, because the diagnostic dilemma of prostate cancer is that while it is a very highly diagnosed prostate cancer, it's not the most common cancer killer. So 1 in 7 men may be diagnosed, but only 1 in 30 of them will die from prostate cancer. So it's that gap that leads to the overtreatment. So the goal of screening, like I said earlier, is to optimally identify the disease at a time point in which you can enact something to prevent it from becoming more serious, minimizing side effects and minimizing, and importantly, avoiding unnecessary treatments. That's where active surveillance really comes in. Now, this is an interesting slide because what it shows is some of the results of what's called the PROTECT trial. And this was published just in 2016 in the New England Journal of Medicine. And this is a fascinating trial. This was a randomized control trial, and as far as I'm aware, is the only randomized control trial of its nature. In this study, if you were diagnosed with prostate cancer based on PSA screening with low-grade, low-volume disease Gleason 6, you elected to enroll in the study. They said, we don't know what to do with this. You could observe it, you could take your prostate out, or you could radiate your prostate. And if you said, okay, I'll be part of that study, they randomized you. The blue line is the radiotherapy group, meaning you got radiation. The red line is the surgery group, and the green line is just watch it. And this is the rates of needing to do something. So everybody who was in the groups, radiotherapy and surgery group, they basically got their treatments right away. But if you were in the active monitoring group, you can see that something happens over the 10-year follow-up of this study. Almost half of those men needed to do something in that time period. So active surveillance does have a rate of detection of the progression of disease. So when you go on active surveillance, that initial step to go forward, you have to monitor it closely. You can't just say this is low volume, low grade disease. Forget about it. About 40 to 50% of those men within a decade are going to need treatment. So how can we improve disease detection? And now we're going to get to some of the things here at NYU that we really focus on. What are tools and biomarkers that we can use to improve upon that PSA? So I've gone through in exhaustive detail some of the problems with PSA. So PSA density, percent free PSA, and some novel markers. Let's talk about these in more detail. What's PSA density? Well, that's how much PSA are you making for how much prostate you have. If you have a 10 cc prostate and you have a 100 cc prostate, you're going to make a different amount of PSA. So if I draw the blood from a man with a 10 cc and test it, and I test the blood out of a man at a 100 cc prostate, they're going to have different PSAs. You have to relate it to how much prostate you have, because how much prostate you have will make more PSA. So let's talk about the numbers there. PSA density is your PSA divided by your prostate volume. Well, how do you know what your prostate volume is? You have to have some form of imaging, and I'll get to that. But the cutoff here is probably about 0.15. Increases your risk if your PSA density is over 0.15. The missing piece here is your prostate volume. If you walk into the doctor's office and get your PSA number, how do you know your prostate volume? And I'll get to that. Now, PSA Isoforms, or also percent free PSA. This is a test that you can draw off of the PSA blood test. It's been around for a long time. Serum PSA, when they draw it off the blood, is measured in two ways. It's either complexed to proteins or it's uncomplexed in the free form. The percent free in that measurement relates to the detection of prostate cancer in a biopsy setting. A higher ratio of PSA in the free form, or a higher percent free form, is associated with a decreased detection. So as that number goes down, your risk or your probability of detecting cancer goes up. This test is really only validated if your PSA is between 4 and 10. So if you have a PSA of 2, percent free doesn't have as much meaning. If you have a PSA of 15, it doesn't have as much meaning. But you have to keep that in mind. So if you're in the 4 to 10 range and you say, well, look, my PSA is 5, I don't know my prostate volume, what's my percent free? And it's 45% free. Well, that actually is very predictive of not having cancer. If it's percent free is 5%, then you would have a higher predictability of having cancer on a biopsy. So I do utilize this test occasionally to try to fine-tune the PSA. Now this is a new biomarker, or a newer biomarker, called the Prostate Health Index. It's a serum evaluation, it's a blood test, and they use other PSA isoforms other than just the percent free, such as the -2 Pro PSA and the free and total. And this has been validated on a number of populations. and it shows improved detection of prostate cancer. Again, it's dialing in the PSA for cancer, not just prostate. Improved detection of the kinds of prostate cancer we're looking for, not those low grades. And it can, if you use this as a reflex test, the PHI test or the prostate health index, your PSA comes back elevated, repeat this test, and it tells you what's your probability of having Gleason 7 or higher on a biopsy. And you could say, okay, well, if it's low enough, you may say, okay, we won't go forward with a biopsy. This is a similar biomarker called the 4K score. 4K score is additionally based on the PSA, but what they're talking about when they say 4K is they're talking about kallikreins. PSA is a kallikrein protein. It's the family of proteins that it comes from, or what it is, essentially. So the 4Ks here are the total PSA, the free PSA, what's called the intact PSA, and another enzyme in the kallikrein family called the human kallikrein 2. They measure all of those. They put them into data along with your age, your history of having a biopsy or not, and your rectal exam, and they give you a % risk of having Gleason 7 or higher on biopsy. What's your probability if your 4K score comes back? It says you have a 24% probability you'll have cancer on a biopsy, Gleason 7 or higher. Now, this was initially studied in Europe and now is validated here in the United States. We do use this. I think this is a useful tool to help risk stratify. Again, they're all based on PSA in some way. There's some other biomarkers that are actually based not on PSA. First one here is PCA3. This has been around for a long time. It's measuring mRNA in the urine. These particular mRNA that it's looking for are upregulated in prostate cancer. What you do in this is you need a urine specimen after a vigorous digital rectal exam, meaning finger goes in on the prostate, presses hard on it, it puts prostatic secretions in the urine, you urinate, and that urine now has essentially DNA from your prostate, and you can measure this. This biomarker can help identify presence of these RNA findings that would be a risk factor for prostate cancer. A similar test is called the Select MDX. This is another urine-based mRNA levels of several mutations, several genes, and predicts the risk of having cancer on a biopsy. That one was validated prospectively. We have used it here at NYU. We're starting to put together our study results on that as well. But these are trying to identify men who could avoid a biopsy just because their PSA is elevated. So the way these tests would work, you'd have PSA, it looks elevated, get the urine-based test. If it looks like it's a low risk, you probably don't need a biopsy. Finally, how do we diagnose prostate cancer? The most important piece in the diagnosis of prostate cancer is through tissue evaluation, prostate biopsy. What I've depicted here for you is a picture of what we call transrectal ultrasound biopsy. Put an ultrasound probe into the rectum, visualize the prostate, pass needles into the prostate, and collect some tissue. This is what the ultrasound imaging looks like. This is a prostate on ultrasound imaging. I put this up there to illustrate a very important point. It's very difficult on this ultrasound image to tell what part of this prostate has cancer in it versus what does not. But it is relatively easy to say where the prostate is. This is the edge of it here. This is the edge of it here. This is why this test has been so widely employed. It's very good at saying where the prostate is, but we've not been very good at identifying where the tumor is in the prostate. So we've developed a paradigm in prostate cancer evaluation to put 12 random needles in the prostate into sextants, 6 spots on each side in 6 zones. It's not directed towards a cancer, but this is the standard of care biopsy. It's been shown that that's the optimal detection approach. Put 12 needles into the prostate and see what you find. It's essentially a blind biopsy, and it's essentially random. That has been our standard of care for many, many years, almost 30 years. Because of that, prostate cancer is a very important point. Prostate cancer remains the only solid tumor that we diagnose by systematic or random sampling. It's the only cancer that we could still say many men are diagnosed with and don't know where it is in the prostate until we remove the prostate. Think about any other organ in the body that has cancer in it. Colon cancer, you can't say that. You wouldn't have your whole colon removed and then say, okay, where's the tumor? You wouldn't do that with your kidney, etc. So all of those aspects are related to the fact that this picture right here has been our only imaging study of the gland for many years, and it cannot tell you what's normal and abnormal. So what did we do to try to overcome that? And this is a good slide because it shows that one way to overcome the fact that you can't tell where the cancer is just sample more of it. And so if you take 6 cores, you average 26% cancer detection rate. If you take 10 to 12, you double it, it goes to 36. But how about if I double that? Well, it doesn't double the detection rate. So you reach a limitation in these blind biopsies. So the fact that you can't see really hinders the accuracy of the diagnosis. Now, it has other implications other than just not being able to see the tumor. First of all, it only samples a tiny amount, less than 0.5% if we take 12 cores. Approximately 30% of the biopsies that we perform without any other guidance other than transrectal ultrasound are negative on the first biopsy, meaning the false negative rate of this approach is 30%. It's pretty poor performance. If you go in and you get a prostate biopsy and the urologist calls you back a week later and says, hey, guess what? That biopsy is negative. You think, great. There's a 30% probability based on this approach that is a false negative. It's a well-known problem. So what do? We check your PSA again, and if it goes up, then we go, maybe we do a repeat biopsy because we may have missed it. Problem with that is the repeat prostate biopsy, or the repeat biopsy, only detects cancer on that one less than 20% of the time. Your PSA goes up again, you still worry. And so you create a cycle. And this has been the standard of care diagnostic pathway for a long time. Now, important tumors also, when we diagnose in this way, are actually incorrectly diagnosed almost 40% of the time. So if I put a needle into the prostate in this manner, get back the report that says, hey, you have some Gleason 6 disease. It looks like it's in a couple spots. Let's treat this. Have your prostate removed. 40% of the time, it turns out you had Gleason 7 or higher. We just missed it on the biopsy. Good thing it was treated, because it was the type that needed to be treated, but it was inaccurately diagnosed initially. So again, this blind biopsy has some serious flaws. This prompted, now this is now, 11 years ago, Pat Walsh. He is down at Johns Hopkins. You may or may not have heard about him, but he is the father of the nerve-sparing prostatectomy. He's the chairman of Johns Hopkins for many years. Okay, he made this comment at our annual meeting 11 years ago. The discovery that would have the greatest impact on prostate cancer would be the development of accurate imaging of the tumor within the prostate. For all those reasons that I just mentioned. Here it is. This is an MRI of the prostate. And what I'm about to show you is how we've finally gotten to a point where I feel we have that imaging tool and what that means for prostate cancer diagnosis and treatment going forward. This is an MRI of the prostate. Now, I showed you some earlier ones, but I didn't go into as much detail. But this is a prostate on an MRI, a multi-parametric MRI. You can see that this picture has a lot more detail to it than that picture on ultrasound that I just showed you. This is the urinary bladder, these are the hip bones, this is the rectum, and here's the prostate gland. Now this tool allows us to identify areas within the prostate that might have more likelihood of having prostate cancer versus not. And there are 3 components to a multi-parametric MRI. I'm going to go through these in detail just so you understand what the test really means. The first test, and this is a picture of that first test, is called a T2 weighted image. It's an anatomical survey of the prostate. It gives us very good anatomical detail of the prostate gland. Areas that look dark on the T2 weighted imaging are suspicious, but it may miss small tumors. It doesn't look at the transition zone or the anterior half of the prostate very accurately, and it can be tricked by things like prostatitis, or if you had just had a biopsy and there's a lot of blood in the prostate. Those are some of the pitfalls with that test. This is an example of a T2 weighted image. See that bright signal on the back half of the prostate? That's normal appearing prostate. A darker area starts to raise suspicion. Is there something going on there? This is a dark area. So that's our first component of multiparametric MRI. The next component is called diffusion-weighted imaging. And essentially what this does is in the MRI scanner, it's using a magnet, and it looks at protons, essentially water molecules, in the prostate. And it looks at their vibration, if you will, because all these molecules have a little bit of motion. And if it's if there's a tumor is cellular growth that outpaces the normal tissue. That's what a nodule is, or a tumor. And so when there's more cells in a small area, the vibration is restricted. The motion of the protons in that tissue are crowded. This is more common in a tumor. And so if you look at that motion, that's what we call diffusion-weighted imaging. A tumor will have restricted diffusion. That's what we call it. It means the protons can't move around as easily in a crowded space. So we have a whole component of imaging on MRI to give us information on this. It's a little bit more sensitive to things like motion and breathing in the MRI scanner, and it doesn't have as much anatomical definition as I showed you with that T2 weighted imaging, but it helps a lot when we're trying to compare the two image sets. So remember, I showed you this T2 weighted imaging here, and there was a dark area. Now this is what we call a diffusion weighted image, and a dark area on what we call the apparent diffusion coefficient, or the ADC map, is consisted with more cells locked in there and less diffusion of those protons, and they match up. So now our suspicion starts to increase that there could be something in this part of the prostate. The final component of multiparametric MRI is called dynamic contrast enhancement. Contrast. It's an IV component. You get an IV, we give you a chemical in the IV, and it goes in the blood vessels, and we can then, with the MRI, see those blood vessels more carefully, more clearly. Contrast enhancement is important because tumors make blood vessels. That's how they feed themselves. They're outgrowing the rest of the tissue. They're sort of on a runaway growth pattern, and so they make what we call growth factors that bring in extra blood vessels. They're angiogenic, we call that. So if you give a contrast agent, you should see more blood flow go to a tumor than to normal tissue. And at the same time, if you take a picture of it over time, because there's more blood vessels, the contrast leaves faster. We call that a rapid washout, early washout, rapid uptake, early washout. So it takes that contrast faster than the rest of the tissue. So we can use this as a third tool in the multiparametric to identify those suspicious areas. This also has some pitfalls. For example, if you have inflammation in the prostate, it's going to have a lot more blood flow. So that may not be as accurate in that setting. It's also heavily dependent upon the software that you're using to detect those differences in the rates of the contrast. But this is an example of how you put it all together. This is a T2 weighted image on the upper left. It's a little blurry here, but there's a red circle around a dark area. Here we have that diffusion weighted map in two types of diffusion weighted imaging, and there's a dark spot or a bright spot in the same spot. And then here is the contrast or the perfusion map showing you where the blood vessel is greatest. Blood flow is the greatest, early uptake, rapid washout, and there is a spot there. So we put it all together and we say, hey, look, that spot looks suspicious. This has been studied in numerous centers, and multiparametric MRI of the prostate looks to be very accurate identifying prostate cancer in the gland. Okay, so that's really the bottom line, is that need for an imaging test that can show us the prostate and show us where prostate cancer might be can be achieved with an accurately performed multiparametric MRI of the prostate. A lot of data. I'm going to just skip through some of this in the interest of time, but if you want to look up more information on this, look at the PROMISE trial, PROMIS. This is a trial that was published in Lancet in 2017. This is level 1B evidence. This is really, really compelling data. It was performed at 11 centers in the United Kingdom. Every man got an MRI. Every man underwent prostate biopsy every 5 millimeters of their prostate. You cannot get closer information to what's going on in your prostate than that, other than just taking it out. And this was 576 men that went through this process. And what they showed was that the MRI was very accurate at identifying men who had prostate cancer, but most importantly, those men were all with elevated PSAs. Around a third of those men who got an MRI had a negative MRI. Very important, because what that means is if your PSA comes back elevated and you get an MRI and it's negative, about a third of those men will have a negative MRI. How many men in those with those negative MRI had cancer? It was very few. In fact, if you looked at only men that had Gleason 4+3, or more on the more aggressive side of Gleason 7, it was like a 2%. So it was very good at saying, do you need a biopsy? If your MRI came back negative, more than likely you're not going to have disease. But what if your MRI came back positive? How do we then go and do a better biopsy? And this has been a lot of what the work we've done here at NYU really focuses on. And we call this targeted biopsy, or MRI ultrasound fusion biopsy. So here we go. We got that MRI. It shows me, hey, there's something up here. How do I get that picture how do I get to that spot on my MRI when this is what my ultrasound looks like? Okay, we have to have some way to get to that spot in the correct way when it comes to doing your prostate biopsy, because the prostate biopsy is not performed in the MRI machine. Now it can be, but by and large, they're performed in the office under ultrasound guidance. It's a local procedure. So how can we get from one to the other? Well, you can do it in the MRI. We call that in-bore MRI biopsy. It requires a lot of special equipment. It requires a lot of time on the MRI scanner. And for all intents and purposes, it's not readily available. It can be done, but it's just not widely utilized because we couldn't serve all of the men in the country that need to be evaluated with the number of MRI scanners and the amount of time that we need. So the other type of approach is to just look at the MRI, then look at your ultrasound and try to find it. We call that cognitive or visual targeting. And then there's what we call software-based or MRI ultrasound fusion. And that is a special piece of equipment that actually takes the MRI image and fuses it to your ultrasound real time and can guide you to the area that you need to sample. This is an example of an MRI ultrasound fusion device. This is called the Artemis. This is what we employ here at NYU for the most part. And what it is it's a software and hardware device. Put your ultrasound probe in here, and this big contraption essentially uses encoders to track where that biopsy is in space, and then can take the MRI and guide you off your ultrasound to where the MRI spot would be. And that's what I use. Now, does that work? Well, here's some pretty good data from our center. If you have, this is called the PIRAD score down here. And the PIRAD score is how the radiologist interprets your prostate MRI. If it's a 1, it's negative. The prostate looks normal. If it's a 2, it's a low suspicion finding. 3, intermediate. 4 is high. And 5 is very highly suspicious. So what was our detection rate of cancer for each of those scores? A 2, you had around a 24% cancer detection rate, and up to a 94 if you had a PIRADS 5. So in essence, if you get a PIRADS 5 on the MRI, it's a very high probability that the needles put in that area are going to tell you prostate cancer. That has also been shown in a number of studies. So I've talked about prostate cancer screening going back to digital rectal exam, bringing in a serum-based blood test that we call PSA, okay? But it's not specific. It has a lot of pitfalls. It's involved with a lot of controversy because of those pitfalls, primarily because it leads to overdetection, overtreatment of low-grade disease. But the other component that really propels that problem is the fact that the ultrasound wasn't able to tell us whether or not you had high-risk disease either. So then you had to do a lot of sampling randomly through the gland to try to make sure you didn't miss an aggressive cancer because the PSA was up, but you would more often find low-grade, low-volume disease, and many of those men went on to get treatment when we don't feel that those treatments were probably necessary because those low-grade, low-volume disease probably wouldn't have killed you. But there is a rate of progression over time, so it is important to watch those things closely. MRI now addresses a lot of these concerns. If you have an elevated PSA, you can get an MRI, bring in some of those biomarkers that I talked about, the 4K score, the select MDX, help identify what your risk for having a disease from a biomarker standpoint is, in coupling it with the MRI, go to the right spot, and you can avoid detection of low-grade disease and increase the detection of the disease we need to know about. Now this starts to sound like an improved screening protocol. What's interesting about it is that if I know where the disease is now in the gland, it also opens a new avenue for treating the disease. Remember what I said earlier was that for many years we didn't know where the disease was in the gland until we took it out after treatment. But now if I know where it is beforehand, it opens the door to treating just that spot. We call that a partial gland treatment option. Now this as a cancer control strategy is something that we use for almost every other cancer. If you have melanoma on your wrist, you don't take all of the skin. You treat the melanoma. This holds true for breast cancer, this holds true for colon cancer, this holds true for kidney cancer and almost every cancer, except for prostate, because we didn't know where it was. Now it is true that prostate cancer often is multifocal, meaning it shows up in more than one spot in the gland. And that's an important thing to remember. But not always. Sometimes it's only in one spot. And if I can identify where that is, you could consider treating just that spot. We call that partial gland treatment or ablative technologies. What I mean by ablation is to treat or destroy just that part of the prostate using an energy source. We have two energy sources we primarily use at NYU, and I'll go into some of this, but just to know that they're basically using an energy source to, in a very controlled fashion, destroy part of the prostate. This one's called high-intensity focused ultrasound, or HIFU, and the other is cryoablation of the prostate, which freezes part of the prostate. This is cryoablation. I'm just going to go into the details of just this because I think for the interest of time, it's important to just understand the concepts. What cryoablation is to say that MRI has identified where the disease is. I've confirmed that. Now, as a treatment choice, if I put a needle in the exact same place using the same principles, MRI ultrasound fusion, going to the same spot, and I create an ice ball in that area that encompasses the cancer, take it down to a temperature where it turns to ice. Think about if you put your hand in a bucket of water and you flash froze it, turned it into an ice cube, left it like that for a few minutes, thawed it out, your hand would eventually, all those blood vessels would have died. And so this is the same concept. It creates kill of the cells that are in that ice block. So it's very different than, say, removing something, but it still achieves cell kill. And this has been shown for many years to be effective at killing prostate cancer. And it was always used to treat the whole prostate for the same reasons that we had to take the whole prostate out or radiate the whole prostate. But now we're talking about employing these type of concepts when we know where the tumor is and focusing the treatment to those areas. So here's an example. This is a prostate MRI, which shows you an area of suspicion on the right side of the prostate. Okay, it's about 6 millimeters in diameter. This gets read as a PIRADS 4 by the radiologist. So like I said, that's a high suspicion area for tumor. PSA was elevated. We checked it. So we do an MRI ultrasound fusion biopsy, and we put targeted biopsies into this area, and they come back and they show Gleason 7 prostate cancer. Now, we still sample the rest of the gland because, like I said, prostate cancer is multifocal, and there is some disease that's not visible on MRI, so we still check the rest of the prostate, and let's say those are negative. So this looks like a cancer that's in just one small part of the prostate. So what could you potentially do? Well, these are some 3D models of needles that could make an ice ball. And this yellow structure is the prostate. This is the rectum. These are the neurovascular bundles. And that green spot is a tumor. Now I have an ability to say, okay, well, what if I put ice balls that look like this that could encompass that tumor in its entirety and freeze it? Well, this is an MRI of before, and this is an MRI of what the prostate looks like after we've frozen and essentially destroyed a portion of the gland, and it encompasses that tumor. So that is an area that we're actively working on here at NYU. We call that partial gland treatment. It's image-based treatment. It requires the MRI of the prostate as a real fundamental piece, but it also requires another fundamental piece being the targeted biopsy, and it really represents a transition from that blind biopsy that was based on PSA to a new paradigm. It does not eliminate the need for treatments like prostatectomy, radiation treatment for the prostate. Like I said, prostate cancer still remains a multifocal disease, and this is not the majority of cases where we can do an ablation, but it is something that will start to enter the language. You will start to hear more and more about it simply because now we have an imaging study that can identify location better. And so it's going to start raising this to the forefront more often. Something we're doing very actively here at NYU is trying to identify and improve the diagnosis of men with prostate cancer by employing these other tests. And the men that might be a candidate for something like this, we can talk about it and talk about utilizing this. Now, these treatments are very early in the United States in their employment to do partial gland treatment. And so a lot of the long-term data is being developed. So it's important to know that. The sort of efficacy of prostate cancer treatments that come from radiation and surgery have many, many years behind them. We're not anywhere near that with this type of approach, but it's going to start to gain interest, and there will be studies ongoing and exploring this. But it's just important to recognize, I think, what the arc here is. The arc is that the PSA test was in advance. It was imperfect. The ultrasound was in advance. It was imperfect. And now we've got an MRI. Of course, it's not perfect. It misses cancers. But we have to start to employ, and the biomarkers are an improvement over the PSA. So we start to put all of this together. And prostate cancer is complicated, but these are tools to try and improve our ability to make a better diagnosis, and in some cases, I feel make a better treatment. Thank you.